So we have a case here where the neurologist has sent me this patient that had pain in his back, quite severe, due to central canal stenosis, and they cored out the canal in the lumbar spine down in this area here. This is his x-rays. But after the surgery, his pain went away, but then he started experiencing numbness in the left leg, which he didn't have before, and cramping when he goes into a certain position. All of these discs are almost gone completely in through here. This one's got some substance still. This one is 50% gone. This one is not in great shape, and that's not good at all either. So almost all the discs are compressed in his spine, which is not great. But we've just got him here. We're just doing the exam, and we're looking at what he can do. One of the things that causes him to cramp is to bend the knees. And when he bends his knees, tell us when he's getting cramps.
Ütle, kui krammid tekivad.
Siit hakkab vaikselt tulema.
Now it's all starting to cramp up. All the muscles, okay, he's starting to cramp on. We don't want to leave it like that. So the key is, but he doesn't have any cramps when we straighten the legs out. The key is that when he puts his knees up, he's flattening his back, pushing it back more, flattening out what little curve is left. He's got almost no curve there. Which is one of the problems. So probably one of the things we're going to want to try to do with him is restore the lumbar curve as much as possible. We might do some decompression, which with his pelvis on an angle, and probably get him a lumbar pump to use daily to increase the angle of the curve. If we increase the angle of the curve, which is what's happening right now when he's lying on his back as opposed to with his knees up, we might be able to get enough pressure off the spinal cord to alleviate his symptoms. I don't know that any form of manipulation is necessarily going to be safe in this case, so we might approach it quite guarded and carefully to make sure that we don't aggravate his symptoms, considering the fact, of course, that he's also had some pretty extensive surgery in his lumbar spine already. Okay, so we'll check the strength now. Let's lift up this leg. Let's find out. He says the legs are strong. Let's find out if they really are. Valus anywhere or numbness? Valus? Cramp. Yeah. So these legs are cramping over. You see the muscles moving? Look at them here. See them? The way they're moving there. So these muscles, there's something causing this, and that's the left leg. That's the leg it's going down, right? Look at that. Those are called fasciculations. It's not normal to have that. Let's see what happens with the right one. Lest?
Tõsta see parem ka samamoodi.
He's getting some fasciculations as well on the right side. They're moving around. You'd have to bring the camera around to the other side to see them. But in here, he's having a lot of pain. If we were filming his face, we would see that he's in quite a bit of discomfort. Ask him if it's difficult. Väga raske.
Raske sul liigutada niimoodi tõsta teda, jah?
Tõsta ei ole, aga siis...
He's making faces when he's holding. Why is he making faces?
Et sa teed, sul näost on näha, et kuidagi nagu ebameeldiv on, jah?
It's difficult.
Yes.
It's heavy.
Siis kui see valus hakkab, siis on...
Okay, now if I put pressure on it, hoia tugevasti, ülest, hoia.
Ära lase alla võjutada.
He actually has strength.
Lase tagasi.
Teise poole.
Teine jalg tõsta üles.
Teise poole, teine.
Ära lase alla võjutada.
He has strength in that one too. So that's an interesting case. So there's some type of fasciculation happening, which is change in the motor control or signal pattern or the gamma bias of the muscle that's causing that fasciculation, probably being originating from the central canal. So, and certainly because of the fact that it's bilateral. Let's just see over here. Pura, hoia. That's also doing the same thing. Pura, hoia. Now we're using different muscles. Still fasciculating in here. Hoia olest. You can see them moving, jiggling. He's getting a cramp. He's getting a cramp. So when he lifts the leg up, we also flatten the spine more, which would put more pressure on the spinal cord. He can't bring. Okay, olest. Varva. That toe doesn't come up. Look at this. Nothing there. So the motor control of L5, there's nothing here. Olest, varvad. These are here. This is nothing. The big toe is lost. Kõrvaks. That was on the right side. Let's try this one. Olest.
varbad enda poole .
This one's also completely weak. He's trying, eh?
proovid praegu tõmmata .
Jaa.
Can't do it.
Yes.
This one? Okay. Big toes on both sides are weak. So we're over on the wrong side there. Here we go. We're looking at extensor hallucis longus specifically to see whether or not anything else is weak. Hoya? Hoya?
tõmba enda poole .
That's interesting. Hoya? So he's got
Yes,
nothing
Hoya.
nothing here on
tõmbab
fibularis.
krampi või ?
Ja siit hakkab .
Hoya?
There is cramp .
Nothing. Nothing. Okay, Lurvox. Hoya? This he doesn't have. He can't even bring this up at all, really. This one is up. So the left one's got, it's more numbness in the left side, but he's got other symptoms. He's got other problems which he doesn't understand because this is not working at all. Anterior, so extensor digitorum in here. Okay, Hoya, Tugavesti.
ära lase alla vajutada .
Desipole. Desipole.
Mul kramp on jalas
You got a
kõvasti .
severe cramp there. Okay. So he's getting severe cramps. Desipole.
teine järg ,
mul
Lurvox.
on sama .
Cramp again.
jälle
Yep,
kramp
so
jah .
everything's cramping up on him. So it's almost a bit of a spastic paralysis, or spastic cramping that's really going on. It's the spasms that he's really having here, which is could be sort of lower motor neuron lesion type of situation to some extent.
jah ,
Same, same, same.
sama . ütle , kui sa tunned kuskil pool midagi teistmoodi .
Same.
siin tunnen paremini kui siinpool .
This is
More
less.
here , this is less .
Let's go down here.
siin ma tunnen siin
More.
parem .
Less , less here , left side .
tunnen ,
sama .
jah .
No,
ei tunne .
not as much. If we look at that, we look at this where the surgical scar is. Your L5S1 level is down below this. So it's almost like they opened up the canal above L5S1 area, and now it might be closing off below where they did the surgery. That's almost my suspicion. Okay, you can put the close
jah
on. Yeah. ,
nüüd võib .
That's almost my suspicion, so we would probably have to get an MRT to confirm that. Whether or not any type of treatment will help is left to be decided. There is a possibility that it could even be coming from a disc origin to some extent, causing some compression of the central canal, in which case non-surgical spinal disc decompression would be helpful, but we don't know. We can try it and see what happens. That's probably what we're going to have to do in this case. I wouldn't be doing any manipulation on this case because it's pretty frank neurological disturbances going on down there, and the manipulation chiropractic might make it a lot worse, so we don't want to do that. So that's what I'm going to suggest to him, and then we're going to have to come back to you with the result, which will probably take at least a month or two anyway to see some changes here. That's basically it for this case. This is Dr. O and the Dr. O Show.